Hello, I am Dr. Parvez Ahmed Rishi. Today's presentation is about pediatric emergencies slide, and if you pay attention, you can recall and you can remember a lot. Gastroenteritis. Major challenges include the assessment of the degree of dehydration and deciding the most appropriate rehydration strategy, the decision to admit. So the first is degree, second is rehydration, and third is admit. So we have gastroenteritis. What are the causes? Most causes will be viral. The most common cause is viral. So you have to encircle this cause. Most common cause is viral. Don't forget. And the most common virus is rotavirus. Is the most common cause, 40 to 50%, and it occurs in winter time. Adenovirus 7 to 17%, bacterial 4 to 10%, Salmonella, Campylobacter jejuni, Yersinia, Enterocoletica, and E. coli are the most common bacterial causes of gastroenteritis. Protozoon, it is Giardia lamblia and Entamoeba histolytica, can cause gastroenteritis. Keep in mind food poisoning, Staphylococcus aureus, and Bacillus cereus. Complications are dehydration, electrolyte disturbance, septicemia, post-infectious lactose intolerance. Important points in history: frequency of vomiting and diarrhea, amount of fluid solid intake, urine output by numbers of wet nappies, changes compared to normal, recent overseas travel. Any significant comorbidities. Degree of dehydration: mild less than 5%, persistent vomiting and diarrhea, little signs. Moderate 5 to 10%, tongue and buccal mucosa are dry, decreased tissue turgor, decreased fontanelles in infants, reduced capillary return, lethargy, fever greater than 10%, signs above plus circulatory compromise, tachycardia and hypotension, oliguria and anuria. Rehydration: fluid loss may be given orally, via nasogastric tube, intravenously. Rehydration oral: for mild dehydration may use water, gastrolyte, isopoles. Breastfeeding should be continued. If vomiting, ondansetron 248 mg. Rehydration nasogastric tube: moderate or not suitable for oral rehydration. Advantage: less likelihood of electrolyte imbalance, quicker return to enteric function, prolonged period of enteric resting may lead to ileus and delay recovery. Calculated volumes can be taken from the RCH guidelines. Gastroenteritis: degree of dehydration: moderate 4 to 6% and severe greater than 7%. Weight on admission kg. In 3 kg moderate we give 0 to 6 hours 25 ml per hour, and in 4 kg we give for moderate 35 ml per hour, and then we give 45. In 5 kg we give 45. That way we give what is the, you have to remember moderate is 4 to 6%, severe is 7%. So we give in moderate dehydration 25% in 3 kg baby, and in mLs per hour, which 7 to 24 hours we give 20 ml per hour. Then here in severe we give 45 ml per hour, and greater than 7 we give 20 ml per hour. So you have a look at this column and have a look at this column. If it is very severe, in 3 kg we give 20, then we give 30, 35, 40, 45, 50, 55, 60, 65, 70, 70. So it is easy to remember. 3 kg, 4, 5, 6, 7, 8. You make a graph in your mind. You make 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, up to 10, up to 10 kg. And here you say 20, 30, 35, 40, 45, 60, up to 60 kg. Okay, so this you remember. And here you say that if you remember this table, you can make out all. The final is you just pause the video and write it down on some paper and then remember it. You don't need to, you need to have a rough idea that the maximum is 20 and maximum at 4 is 30, maximum is this. If you know the maximum, then here you can see the maximum again is the same. If you remember this column, you as well remember this column, right? If you remember this, so you as well can subtract 20 and it will be 25, like that. You can do a mnemonic, and you just need to have a rough idea. When you will be in general practice, you will have this chat with you always. Gastroenteritis, rehydration IV. Cases of severe dehydration that need initial fluid bolus resuscitation. Children unable to tolerate nasogastric rehydration. Resuscitation fluid, normal saline. Maintenance IV fluid 0.45, NaCl with 5% glucose. Rehydration IV. Calculate of fluid deficit. Percent dehydration into weight. Percent dehydration into weight into 10. So you have to remember this formula. This is very important formula. Percent dehydration weight into 10. And maintenance fluids. Hey guys, this is very important, and this is body weight. First 10 kg, second 10 kg, third 10 kg. You remember first 10 kg we give 100 ml per kg. This is fluid requirement per day, and this one is fluid requirement per hour. In first 10 kg we give 100 ml per kg, and for per day. If you have to calculate per hour, you remember that here we say first 10 kg, second 10 kg, third 10 kg. It is easy to remember 4. You remember the digit 4 and remember 4 ml per kg. Then divide it to half, 2 ml per kg, and divide it to 1 half, it is 1 ml per kg. So this is the easy formula. If you remember this one, it is good for you. But if you cannot remember that, for first 10 kg give 100 ml per kg. So for next second give 50 ml per kg, then give 20 ml per kg. That's better for you. Gastroenteritis, hypovolemic shock, intravenous or intraosseous dehydration, 20 ml per kg of normal saline. Children with more than one sign of shock should be given high flow mask oxygen, and if there is no improvement, give a further 20 ml per kg. If signs of hypovolemic persist, the child should be monitored in ICU. You remember, pay attention, this is hypovolemic shock. We give IV fluids or intraosseous rehydration. So you pay attention, always remember 20. When you are dealing with hypovolemic shock, you are dealing with 20 ml per kg, normal saline. Always remember normal saline. Then you remember that children with more than one sign of shock should be given high flow mask oxygen. You give 20 ml of normal saline and high mask oxygen. If there is no improvement, give a further 20 ml per kg. If signs of hypovolemia persist, the child should be monitored in ICU. Finding a UTI in sick child does not exclude another site of serious infection. Example, meningitis. 2% of young children will have asymptomatic bacteriuria, and this may not be the cause of acute presentation. Clinical feature: non-specific fever, irritability, poor feeding and vomiting. Loin or abdominal pain, frequency and dysuria. Urinary dipstick test is only a screening test for UTI. It has poor sensitivity and specificity. Urine dipstick test, it is a screening test, you should remember, for UTI. It has poor sensitivity and specificity. Not all organisms produce nitritis, and also they take time to develop. Not all patients with UTI produce proteinuria. Leukocyte esterase will be produced only when the WBC count is high. So urine collection, what you do in urine collection? Midstream. You remember one thing, that is midstream. Pure growth of 10 raised to power 8 colony forming unit per liter is proof of UTI. Colony count of 10 raised to power 5 suggests infection. Colony count of 105 suggests infection. Clean catch same as above. Catheter specimen, pure growth of 10 greater than 10 raised to power greater than 103 colony forming unit per liter, failed SPA. Suprapubic aspirate collection, any growth indicates infection. Urinary tract infection treatment, admission, unwell, age under 6 months. Gentamicin 7.4 mg per kg, 240 mg IV daily, and benzalpenicillin 50 mg per kg, 3 g IV 6 orally for children only 1 month of age. Urinary tract infection continued. Treatment: trimethoprim 4 mg per kg, 150 mg maximum. Only tablet, generally available in community, RCH, pharmacy. Make 10 mg/ml per suspension for RCH patients. For MCQ exam, you remember only the name trimethoprim. No need to remember dosage. Hey guys, remember trimethoprim. Trimethoprim and sulfamethoxazole 8 mg 40 mg per ml. Remember trimethoprim, sulfamethoxazole. Cephalexin 15 mg per kg. No need to remember 15 or no need to remember anything. But remember 2 years 7 days if old. If less than 2 years 7 days if older. 10 days, give for 10 days total. If less than 2 years. If it is older, give for 7 days. You remember this. And let's go back. Urinary tract infection. Children with atypical UTI, those not responding to treatment with 48 hours, and boys less than 3 months of age should have a renal ultrasound to exclude renal obstruction. Children under 6 months should have a renal ultrasound within 6 weeks of diagnosis. Older children do not require an ultrasound post first UTI, but should have a renal ultrasound for recurrent UTI. MCUG should be done only if ultrasound is abnormal. Atypical UTI or recurrent UTI or family history of reflux. If MCUG is positive, perform DMSA after 6 months. So, if you have to see whether there is scarring of kidneys or not, the investigation of choice DMSA. First investigation MCUG should be done only if ultrasound is abnormal. before MCUG drew USG, atypical UTI or recurrent UTI or family history of reflux, some degree of reflux, and misleading finding, which look similar to scoring, can be present soon after a UTI. Thank you for watching. Please like and subscribe and comment to support and help to improve and help to take this slide to people who cannot afford coaching and who cannot afford to go to other centers. Thank you.